Hello, everyone, and welcome to the latest episode of our psoriatic arthritis podcast series, alongside our RA and AxSpA podcasts. We'll be bringing you monthly slide decks to help keep you up to date with the latest research and publications in the field of PsA. My name is Peter Nash, Professor at the School of Medicine, Griffith University, and Director of the Rheumatology Research Unit of the Sunshine Coast in Australia. And joining me today is Laura Coates, Associate Professor at the University of Oxford's Nuffield Department of Orthopaedics, Rheumatology and Musculoskeletal Sciences. We're also very fortunate to have Philip Mease, who's Director of Rheumatology Research at the Swedish Medical Center and Professor at the University of Washington School of Medicine in Seattle in the US. Today's discussion will focus on two papers. The first, which is a post hoc analysis of patients with active PsA in the Be Optimal and Be Complete studies up to 52 weeks. And the second is looking at matching adjusted indirect comparison, the MAIC study, to compare the effectiveness of Bimekizumab, the IL-17A and F inhibitor, and risankizumab, the P19 IL-23 inhibitor, in patients with psoriatic arthritis. Over to you, Phil.
Except it's me.
Yeah, but it says over to you.
It
Thank
does.
you. So, Laura, can you continue, please?
Thank you, Peter. So today's first paper is from Professor Ian McInnes and colleagues, entitled Efficacy and Safety of Bimekizumab in Patients with Psoriatic Arthritis with or without methotrexate, looking at 52-week results from the two phase 3 studies of bimekizumab. So this is a post hoc analysis, and it looked at data from Be Optimal, which was the phase 3 study looking at patients who are biologic naive, and Be Complete, which included patients who had a prior inadequate response or intolerance to TNF inhibitors before. And then both of those patients in Be Optimal and Be Complete went into the Be Vital open label extension trial. So all of these are randomized control trials looking at bimekizumab in PsA. And obviously, as you mentioned, bimekizumab is a monoclonal IgG1 antibody that blocks both IL-17F and IL-17A. So it's a little bit different from the other IL-17s that we've had previously. And it's been around now for a little while. It's licensed in multiple countries at the moment. And we've had data previously from these studies to show efficacy and safety out to a year. But the aim of this analysis was to look at the clinical safety and efficacy of bimekizumab in those who were and were not taking methotrexate. And that's across both of the studies, so the biologic naive patients and the TNF inadequate responder patients. So in the trials, patients had been randomized to bimekizumab, 160 milligrams every 4 weeks, placebo, a reference drug of adalimumab, that was in the biologic naive study, the Be Optimal study only. And then from week 16, the placebo randomized patients switched over to receive bimekizumab. So when they looked at the outcomes at week 52, we saw similar proportions of bimekizumab treated patients achieved ACR 50, whether they were on methotrexate or not on methotrexate. And overall, it's around 55% in both of the studies who hit that ACR 50 outcome. And it's very similar in the methotrexate or with or without groups. When they looked at skin clearance, this also looked very similar. So sometimes we think maybe methotrexate makes more of a difference for the skin. When they looked at PASI 100, and when they looked at overall disease control with minimal disease activity, again, both groups looked similar. So whether you were on or off methotrexate, and whether you were in the biologic naive or the biologic experienced study. And there were similar trends seen in those patients who had originally been on placebo and then switched over to bimekizumab treatment after week 16. And obviously, as well as efficacy, we always want to know about safety, and that looked comparable as well. So between those different subgroups, it looked consistent and very similar to the prior data that we've seen with bimekizumab. So overall, at least in this sort of I guess, medium-term 52-week data, we can see consistent and sustained efficacy out to a year in the biologic naive and the TNF experienced patients, and that was regardless of whether they received methotrexate or not. And obviously that's not randomized, that's whether the patients enter the trial already on methotrexate or not. The results again looked pretty similar between the B optimal and the B complete populations, so there wasn't a big difference between those who were TNF naive and TNF experienced. And bimekizumab was pretty well tolerated in the patients in both groups as well.
So, Laura, why do you think it's important to have efficacy without methotrexate in a PsA population?
Well, I mean, we all struggle with methotrexate, don't we, with a number of our patients. So PsA, first of all, methotrexate isn't that nice. A lot of patients don't want to take it. They feel queasy on it. They feel a bit hungover or unwell with it. And a lot of patients, given the choice, would like to stop their methotrexate. And I think particularly for our PsA patients where we see higher rates of obesity and fatty liver disease and other issues, then it does make life more complicated. And it brings into question, I guess, the risk benefit. Most of the data we've had before has been around TNF inhibitors in the longer term, suggesting that maybe being on bit of methotrexate was helpful in terms of longevity of response. But all of the analyses that we've seen of these clinical trials don't seem to show a big difference whether you're on methotrexate or not, at least in that sort of 1 year follow-up.
Excellent. And Philip, is there an advantage to blocking F as well as A? We've got a couple of other 17 inhibitors we've been using for a long time. Do the clinical trial program convince you there's an advantage in blocking F?
The data out through week 16, week 24 is actually fairly similar between all of these products. If you look at some of the endpoints, let's pick minimal disease activity as an example. We did see higher achievement of MDA in the bimekizumab treatment program as compared to the IL-17A inhibitors. But in many of the other outcomes, they were fairly similar. What I'm really impressed by is this week 52 data that Laura has presented. We're seeing quite sustained and good benefit. And that's what I'm going to be looking for as we hear data at upcoming meetings about the year 2 data, where again, I'm anticipating that we're going to see some sustained response. So that's really where I am most curious about whether there might be some differentiation.
Interesting, yeah. And I just wondered, Laura, if you could comment on where you see the role of these 17s in the treatment algorithm, because even though we're doing pretty well to get MDA around 50%, what about that other 50%?
Yeah, I mean, I think that's tricky, isn't it? We've seen kind of a ceiling really of how good we can get responses in most of the phase 3 trials coming through, unlike in psoriasis, where some of the newer drugs have very much obviously beaten existing therapies as they've come through. We haven't got the same data in rheumatology. So at least for the arthritis outcomes, we haven't ever seen anything, beat another drug head to head. And so we've seen sort of similar outcomes to TNF inhibitors. I think the key is, well, I think there's probably multiple issues. So part of the issues is our outcome measures aren't as specific. So some of the pain that people have from long-standing disease and damage and things will impact on your chances of achieving good outcomes like MDA or ACR70. So I think we probably need to be treating earlier, ideally. And that means diagnosing earlier for PsA as well. But I think it's, as we move forward, hopefully we can move into an era where we can pick the right drug for the right patient, and trying to match up with precision medicine which patient would benefit best from a TNF inhibitor or an IL-17 inhibitor will hopefully mean that we're kind of avoiding this almost one size fits all kind of run through different options approach that we're more reliant on at the moment.
Bill, do you think this means we should be doing trials of combo from day one versus mono? like we've been doing. If we seem to treat for 6 months and then swap and one drug at a time, do you think those trials are worth looking at?
So are you referring to putting two biologics together and
Yep.
really hitting it hard at the very beginning? I
From day
think,
one.
yeah, I think you're absolutely right, at least from my perspective. I think that we are seeing one example of that we haven't seen the data yet. That's the Affinity trial, where a IL-23 and a TNF inhibitor are put together and comparing them to the IL-23 inhibitor alone. These are in patients, though, that have already failed one TNF inhibitor. I think more of these kinds of studies should go forward so that we get to be a bit more like oncologists in our ability to try to bring two or three different drugs to synergize and really hit the disease hard at the very beginning and then back off.
Excellent. Thank you very much. Would you like to continue with the second paper, Philip?
Thank you, Peter and Laura. I will now move on to the second paper, authored by myself and fellow co-host Peter Nash, entitled Comparative Effectiveness of Bimekizumab and Risankizumab in Patients with Psoriatic Arthritis at 52 weeks, assessed using a matching adjusted indirect comparison. Bimekizumab's efficacy and safety were recently established in two phase 3 randomized controlled trials, and Laura has been going over some of that data with you. These were the B-optimal trials in patients who were bio-DMARD naive, and the B-complete trial in patients with previous inadequate response or intolerance to a TNF inhibitor. Previous MAIC analyses have demonstrated that bimekizumab was more favorable in achieving positive treatment outcomes in patients with PsA who were both bio-DMARD naive and TNF inadequate responders. In the absence of head-to-head trials, which are expensive and require lots of patients to do them, and there have been very few in psoriatic arthritis, we fall back on other approaches to try to compare medicines to one another. One method is a network meta-analysis, or NMA, but that requires that there be a placebo as anchor. And usually we don't have placebos beyond week 16 or week 24 in clinical trials. So if we want to look at longer term data, like 52 weeks, we need to do what's called this matching adjusted indirect comparison, or MAIC. In this study, MAIC were conducted to assess long-term efficacy of bimekizumab versus risankizumab at 52 weeks in patients with PsA who were bio-DMARD naive or TNF inadequate responders. The relevant trials were systematically identified. And there was a special matching, so to speak, for the MAIC, and this included matching of patients based on age, sex, methotrexate use, HAQ score, body surface area greater than or equal to 3%, swollen joint count, tender joint count, and disease duration. For patients who were bio-DMARD naive, individual patient data from B-optimal were matched with summary data from KEEPSAKE-1, who were also bio-DMARD naive, and there were similar numbers of patients in these two trials. For patients who were TNF inadequate responders, individual patient data from B-complete, 267 patients, were matched with summary data from the TNF inadequate responder patient subgroup in KEEPSAKE-2, which was 106 patients. To adjust for cross-trial differences, patients from the bimekizumab trials were reweighted to match the baseline characteristics of patients in the risankizumab trials. Adjustment variables were selected based on expert consensus and adherence to established MAIC guidelines. recalculated bimekizumab week 52 outcomes for ACR 20, 50, and 70 response criteria and minimal disease or MDA index non-responder imputation were compared with risankizumab outcomes via non-placebo adjusted comparisons. What were the results? In patients who were bio-DMARD naive, bimekizumab had a significantly greater likelihood of response than risankizumab at week 52 odds ratio of ACR 50, 1.52, and ACR 70, 1.80. In patients who were TNF inadequate responders, bimekizumab had a significantly greater likelihood of response than risankizumab at week 52 odds ratio, ACR 20 of 1.78, ACR 50 of 3.05, ACR 70 of 3.69, and MDA achievement of 2.43. In conclusion, using MAIC, bimekizumab demonstrated a greater likelihood of efficacy in most ACR and MDA outcomes than risankizumab in patients with PsA who were bio-DMARD naive and TNF inadequate responders at week 52. Over to you, Peter.
Thanks very much, Laura. The TNF-IR data is certainly amongst the strongest we've ever seen with the 17 clinical trial programs across the board. Do you think this drug will be pushed into a TNF-IR situation in the UK?
Yeah, so we are very much being pushed to use biosimilar TNF first line because of cost reasons, unless there's a good reason why that's not the best drug for the patient or a TNF is contraindicated. So I think certainly in the UK, and I think probably commonly across a lot of countries in Europe, the kind of battle is for second place, is for the second line agents, because the majority of patients are likely to get a TNF first line at the moment. So I think that is probably where the fight for getting your drug recognised is. And as you say, I think the data here for the TNF experienced patients was really basically the same as those who were TNF naive. And that's not been the case in a lot of studies. We've seen a drop off in efficacy when patients have previously failed another drug.
Okay, so we're fortunate here because we can pick and choose without that kind of being forced to use a biosimilar issue. And it's almost head-to-head initiation, 17 and TNFs, I think. So, Philip, tell us how the clinician should think of these MAIC studies. How should they interpret them? What should they make of the MAIC studies? We certainly find them very helpful to show our regulators, because there's never any head-to-head, to get drugs listed and priced, etc. What should the clinician do with an MAIC study?
So what I do with my patients is to comment about either MAIC or NMA studies that have been done, since there's such a paucity of head-to-head trials in psoriatic arthritis. And so I can at least say that a drug is at least comparable or possibly slightly more effective in this type of analysis. I comment to them that even though it's not head-to-head, it's fairly rigorous way of looking at a comparison. And so we use it to help reassure them that there's good data on the efficacy of a drug. And importantly, in this particular MAIC approach, where we can look at longer term 52-week outcomes, that there's durability of effectiveness.
Okay, and Laura, what about MAICs and yourself? How do you use them, and what should the clinician think about them?
Yeah, I think similar. I think we've always got to be a bit cautious that whenever you try and kind of match patients statistically, you're matching on a few things. You can there's a lot that you can do with statistics, which is helpful. But these are different trials in different populations, in different countries, different years. So there are going to be some differences that we can't account for. But I think, like Philip said, at the moment, we don't have great head-to-head data for most drugs in PsA. So this is as close as we can get. And I think moving forward, we are likely to see a few more head-to-head trials, which will be great to see that kind of definite comparison. But at the moment, this gives us a reasonable idea. So I think, like Philip said, you can say these drugs at least look comparable, and you can be pretty confident on that. And maybe this one looks a bit better in the analysis, but with some caveats around how that's statistically kind of estimated.
Okay, excellent. So thank you for joining us for this PsA podcast brought to you by the Immune-Mediated Inflammatory Disease Forum. I really hope you enjoyed and found it useful. If you did, don't forget to subscribe to our channels on YouTube, Spotify, SoundCloud, or wherever you get your podcasts, so you won't miss any future episodes. If you want to read more about what we've discussed today, visit imidforum.com. You'll find detailed summary slides and today's publications. See you next time. Thank you very much, Philip and Laura.